Hi, I'm Alex Spira. I'm a medical oncologist with Virginia Cancer Specialist in US Oncology, and I'm here with Dr. Sabari today to talk about some of the updates from ESMO this year. It was a packed ESMO, and there was a lot of new information, especially in regards to EGFR targeted therapies. And we'll spend a little bit of time today talking about the CHRYSALIS study, specifically with amivantamab and lazertinib. So, Dr. Sabari, what are your initial thoughts about this?
Thank you, Dr. Spira. So Josh Sabari, Thoracic Medical Oncology at NYU Langone Health, Perlmutter Cancer Center in New York. Looking forward to a great discussion on EGFR. It's near and dear to my heart. So the CHRYSALIS study is a very interesting study. So let me just frame this a little. This is for patients who have progression on third-generation EGFR TKI, and I think we'll really focus on that subset of patients today, Dr. Spira, if that's all right. I thought very impressive. So 36% response rate for patients who have progression post third-generation EGFR TKI. Now, what does that mean? So what resistance mechanisms are seen in that setting? So post-Tagrisso, most patients are, developing a sort of smorgasbord in New York. That's a wide variety of alterations, resistance mechanisms. The most common ones that we see are c-MET, amplification in the 15-20% range, and C797S, a point mutation, also about 15 to 20%. And remind me, we can talk about the blue compound preclinically as well this weekend. But in that patient population, J&J developed a compound, amivantamab, which is an EGFR bispecific antibody that blocks both c-MET and EGFR. Dr. Spira, what do you think about the mechanism of this drug and its sort of the bispecific nature? Do you think this has a real sort of modality moving forward?
Yeah, so I think it's a phenomenal way to address this. I mean, as you talked about this, Josh, is that the major two areas of resistance are C797S and c-MET. So I think this hits those two major things on both ends. Secondarily, it's a different mechanism of action, right? I mean, osimertinib is a small molecule that gets into cells, and this really binds on the outside of cells. So I think there's a separate view that even if you don't have those mutations, there's a reasonable novel mechanism of action to attack this. So I think it attacks things on both ends. And I think, to me, this is a long ongoing study. This is in essence, the end of a phase 1 study. Previously, both molecules were studied separately. And we found, I think, first of all, that you can give both together in full doses, which is great. It's never a fait accompli. But more importantly, you can keep the lazertinib on. And I think from my standpoint is the small molecules still have a big role in CNS penetration, right? I mean, a lot of these patients, the drugs will fail them in terms of brain metastases or brain relapses. So the combination there is really getting, I think, at two major issues for this. So I think mechanistically it sounds great. And I think scientifically there were two things. We should focus on the refractory cohort. There was about I think 37%, call it more than 1/3 response rate, which is great. There was significantly more benefit than that. But in this setting where, you're basically obliged to do chemotherapy, it has a real track record. I think the secondary interesting point that the response rates in the naive population were 100%.
Right.
It's really hard to know what to do with that because it's probably lazertinib. It could be both, right? But the question is in that range, the fundamental question is how durable will those responses be? How long will they be? And is it worth the slightly increased toxicity, right? So I think in the frontline setting, there's some great questions. But I think for me, the big take home is, as you said, is in this relapse refractory population. What do you think about the toxicity, Josh?
Yeah, so I mean, toxicity is interesting, right? So we know from amivantamab, the EGFR bispecific antibody, there is this interesting infusion-related reaction. So about 65% of patients on day 1 of the infusion will have this sort of infusion reaction, abdominal discomfort, this sort of heat, flushing, potentially even fevers and chills, and interestingly mitigated very well by splitting the dose over 2 days and pre-treating with steroids and Tylenol and Benadryl. So to me, as an investigator and as a clinician, the infusion reaction was not such a major issue clinically. I think out in the community, it's going to be important that we monitor this and watch this closely. More interestingly to me, the toxicities that we're seeing are these EGFR-mediated sort of, on-target tox, right? wild-type inhibition of EGFR, such as the rash and the diarrhea, not uncommon to what we see with other EGFR inhibitors. To me, overall, I was not that impressed with the toxicity. Obviously, amivantamab on its own has some tox. Combining with lazertinib did not seem to significantly increase the toxicity. And I agree with you, Dr. Spira, that getting CNS penetration with this combination is going to be critical. One of my major concerns with this drug, amivantamab, was lack of CNS activity. Now with the lazertinib combination, we're seeing hopefully, or we're going to see hopefully, robust CNS activity. So tox to me, not such a major issue for the compound. And then, more importantly, I think we're going to see great activity moving forward. Alex, do you think this drug has a potential role then or this combination, I should say, amivantamab and lazertinib, for moving into the frontline setting down the line?
So I think there's a lot of interest in the front line, right? I mean, I think the challenge that you'll have in the front line is as follows. Number one is that osimertinib is a very well-tolerated drug with really minimal side effects. And it's oral, right? So it's not just, is this a better combination? And if it's a better combination, great. But it's not just adding a better drug. It's the toxicity that is clearly increased with the bispecific. And then secondarily, the administration of an IV infusion, right? I mean, it is a little tough thing for patients to swallow in that scenario. That being said, the response rates of 100% are phenomenal. And I think, the frontline studies do need to be looked at very closely to see how well it works and see how well it works for the long term. The challenge is, as you know, is that, the median PFS and OS, the median PFS for first-line osimertinib is phenomenal. So it's going to take a long time to show some really good positive data. There's also some other combination studies in the works, specifically OC with chemo. So it's an interesting landscape that is, getting competitive, which means it's going to be hard to accrue patients and also hard to show a true meaningful benefit. That being said, if you can delay the time of resistance and get these patients more time, I think there's a huge interest there for all of us. And I think it'll be exciting to see how this all plays out. I think the first line studies that are being planned with this combination are super exciting. There's a huge interest to enroll. So, and the last point, Josh, is just to echo what you said. We've had a whole bunch of patients on the study. While there is more to toxicity than with single agent osimertinib or lazertinib, it's very manageable. The infusion-related reactions are not a big deal for most people. And certainly, the EGFR wild-type toxicity is certainly manageable as well. What do you think about the up-and-coming studies, and what do you think the role is going to be for this, and what's the development process looking like?
Yeah, I think it's really interesting, and I'm pretty new at the oncology game and sort of in thoracic oncology, and I sort of developed in the erlotinib, sort of gefitinib era, where you always wanted to look at another TKI that could potentially have better resistance coverage. Obviously, with second gen afatinib, we still saw T790M emergence, and with osimertinib, we thought we had the best drug on the planet, and it is a really good drug. You mentioned PFS, 18, 19 months. We saw overall survival from Dr. Amaligan recently in the New England Journal paper, 38, 39 months. So pretty impressive data. The question is, how do we build upon that? How do we improve upon that? And, the heterogeneity of post-third generation EGFR TKI resistance mechanism is a complex problem. It's complicated. So lots of questions of, looking at, if a patient gets a first gen inhibitor, second gen inhibitor, then goes on to a third gen inhibitor, is that different than a patient, evolutionary wise, than a patient who just got a third gen inhibitor? So I think it's going to be complicated. I think the easier play here is to think about moving these drugs into the front line. So Dr. Spira, I think you're working on one of the frontline studies of chemo plus an EGFR inhibitor. Do you think that's a better opportunity or better approach for preventing resistance mechanisms, sort of hitting with a blowtorch versus using a targeted therapy combination approach from the get-go?
So I always think that the targeted therapy approach, it's the scientists in both of us, right? Here you have a specific problem. So I think the scientist in me wants to believe that the targeted approach is going to be better. So I think those are going to be the approaches. Now, whether or not it's looking at amivantamab and lazertinib in combination with chemo or chemo plus OC, I think the jury's going to still be out for a very long time for that. It's just going to take a while for those studies to accrue. And then you have such long, durable PFS and OS, it's going to take a while to really show the benefit. So we're not going to have that information in the next 12 to 24 months by any stretch. But I do think, for me at least, it's a targeted therapy. For me, and I'm curious what your take is on this, is clearly there's a big understanding that, these drugs we believe work in C797S and c-MET, but there's also obviously the theory that it can work in any mechanism of resistance, just looking at the, the monoclonal and the way it works. Are you checking people for mutations post-osimertinib? Most people aren't, right? And it's been hard enough to check in the frontline setting. What are your thoughts? Are you checking now, or are you going to check more?
Yeah, so I'm checking in plasma. I mean, usually I use Garden 360 because it's covered and it's sort of easily accessible, but a biopsy is really a discussion with a patient, and oftentimes it doesn't really guide therapy, as you mentioned, Dr. Spira. So, it's a tough question. It's a tough call with patients. Now, I have identified patients with, sort of obviously transformation, and when a patient has rapidly growing disease, it's important to biopsy to rule out squam transformation or small cell transformation, but you can count those on a hand, right? So I think the key question here is this going to get approved broad, potential resistance mechanism, non sort of biomarker selected, or is it going to be biomarker selected? And I think that with the lazertinib combination with amivantamab, they're going for a more broad approach. If you looked at the earlier phase 1 study, one of the cohorts were selecting for patients with c-MET or C797S or other alterations. But I think, thinking about sort of the broad applicability of this compound, in order to really move it forward, I do think it needs to be a sort of more broad approach. And to that point you made earlier about this blocking other, mutations in EGFR, we see a, accelerated, not an accelerated approval, excuse me, a breakthrough designation. That's where it is. There's a breakthrough designation there. So I do think we're going to see this drug have activity broadly in EGFR. And again, the mechanism of action is unique to this bispecific approach. And, it has potential on-target activity binding the receptor in the membrane. It potentially also has immune activity. Again, I haven't seen great preclinical data to date, but it's an interesting potential combination across all resistance mechanisms. But I hope for this drug, a future would be to move it to the frontline setting. But you're right, Dr. Spira, we're not going to see results until 2 to 3 years because of how good osimertinib is in the frontline setting.
Yeah, Dr. Sabari, you also mentioned a lot about the Exxon 20, and there was not a big update here at ESMO, but there's been preliminary data presented before us, so I think that's going to be the next exciting thing. I think we only have a few minutes left. So, it's interesting because I was looking at all the ESMO online information this year, and there was a lot on EGFR. I mean, I think 2 things that I noticed was the blue molecule, specifically looking at some resistance mutations. There was also a lot about VEGF and osimertinib, or some of even the first generation drugs. And to me, that was plus minus. I think there's some interesting positive data, but nothing really panned out. Initially, last year that was a new and up and coming thing, and for me, that was a little bit less of an issue based upon some of the survival statistics. I think also part of the issue is we're all, in the targeted therapy world, we want to think about a target, and we're hard pressed to really see the role of VEGF inhibition there. I'm curious your thoughts, and what do you think about the blue molecule from Bluepoint?
So I'll start with the blue molecule. I mean, preclinically, it looks really exciting. It hits, triple mutes. It hits D790M and C797S. So I think that's a really exciting potential. It's a 4th-gen allosteric inhibitor. I mean, we've seen other allosteric inhibitors in this space have some toxicity. So, I'd be excited to test this drug, sort of moving down into the future. Again, preclinical data only. We don't have any human data to date, but definitely a move forward. I mean, we know that C797S has been very difficult to target in our patients. And you're right. I mean, there was a ton of EGFR data presented this week, and I think that's a really important sign and sort of litmus test of our field and how active it is, and how we need therapies for our patients in this space. So I do think it's a rapidly evolving space. Now, interestingly, a lot of the studies, as you mentioned, focusing more on the early line or frontline setting. I was involved in an early study with a first-gen inhibitor and Avastin, PFS improvement, but unfortunately no OS, and it seems like that sort of pans out as well here. We have an ongoing study with osimertinib and ramucirumab right now, a randomized phase 2 study, and maybe that will be less exciting at the moment, but is ramucirumab potentially different than bevacizumab? We'll see. I don't really clearly understand the rationale for combining a VEGF inhibitor with a EGFR inhibitor. But there is some preclinical data to support the combination. Again, I think the point being we need better strategies from the frontline setting, and we can't become sort of complacent with a 17, 18-month PFS with osimertinib. We need to improve upon that. And when I tell a young patient who's newly diagnosed with EGFR mutant lung cancer, exon 19 del or LA58R, that this drug will work for a time, but not forever, it sort of ekes me inside. I wish we had better potential opportunities.
No, I agree completely, Dr. Sabari. I mean, this is, we got, for the last 12 or 18 months, we kind of got away. There was a big excitement. And one of the studies was the update on chemotherapy, one of the Empower studies, I think 150, with paclitaxel, bevacizumab, and atezolizumab. And it got a little bit away for about 12 to 24 months. So it's super exciting to kind of see we're back on, let's really focus on the targets and mechanism of resistance. And we are. So with amivantamab and lazertinib, there's clearly thinking about that. So, it's back to being a super exciting time where the science really trumps everything. I think we're just going to have to see how it's all going to play out, which is not 100% clear right now. So I think we're pretty much done on time. So I thought it was a great ESMO, a lot about the EGFR world. So very exciting there. Any last comments, Dr. Sabari?
No, I mean, I think this is an exciting time in the targeted therapeutics field. I think it's exciting for our patients. A couple other drugs we didn't mention, but the U3-1402, another, it's a HER3 ADC. Also, with 25, 30% response rate post third generation EGFR TKI. So I think this is an interesting time. Hopefully, as you mentioned, we move away from this sort of flamethrower approach of using chemo and immunotherapy in this setting. We know that there are some potential toxicities there, and I'm really excited to getting back to looking at targeted therapeutic strategies in this patient population.
Yeah, no, agree completely. And the last thing I'll say is, once my patients have been on a targeted therapy, that's all they want. So they're very hard pressed to switch to something that's the flamethrower nuclear bomb approach, which is chemotherapy, right? So it's super exciting to have these options both in trial and hopefully off of trial as they get FDA approved. So thanks very much. Thank you, eCancer, for having us.
Thank you.